Hello everyone, how are you? Today, let's try to find a periapical cemento-osseous dysplasia on this panoramic radiograph. I'm going to adjust the contrast as best as I can for you to have a chance to evaluate this patient's panoramic radiograph and see if you can determine the location of a periapical cemento-osseous dysplasia. Let me magnify and we'll take a look at the maxillary right quadrant first and then go over to the patient's maxillary left quadrant. And then let's come down to the lower arch. First of all, we do see impacted tooth number 17 with a large or severe periodontal bone loss involving number 18. And let's go over to the other side. Given the name periapical cemento-osseous dysplasia, in most cases these lesions will occur in the periapical lesion or area. So you want to look for the periapical areas. Again, I'm noticing for occasional bone loss involving tooth number 31. By now, if you have spotted in the anterior mandibular region, you're absolutely correct. I've already given you the diagnosis, right? But if you didn't know the diagnosis and if you saw something like this, you should absolutely consider periapical cemento-osseous dysplasia as your differential or in your differential diagnosis. So let me see if I can zoom in even further to better visualize the area. Based on what we can tell, these two teeth, let's see, that would be 23 and 24. They don't have any visible restoration. It's hard to tell whether it has caries or not, given the loss of spatial resolution seen on this panoramic radiograph. But if we look down below, we do see mixed density lesion here, kind of at the apex and in between the roots of these two incisors. So there's an amorphous opacity with radiolucency surrounding the area. And while it is difficult to interpret, perhaps there may be something going on in this area as well, maybe even here, right? But it's hard to say. So we want to better evaluate this area by taking a periapical radiograph. So let's take a periapical radiograph of this area. So now I have pulled a periapical radiograph of this area, once again, number 23 and 24. And we can better visualize or the details of this area absolutely much better than the previous panoramic radiograph, right? Here, now we can distinctively visualize two separate periapical cemento-osseous dysplasia. Unlike on panoramic radiograph, we were able to see this, but we weren't so clear about this lesion. Also, the bone level wasn't very clear on panoramic radiograph, but as we can see on this periapical, there's a severe, almost near complete loss of bone on number, this would be 25, and still very severe bone loss extending to the apical thirds of number 23 and 24. So looking at this lesion more carefully, again we see kind of amorphous radial opacity with radiolucent rim, and likewise here there's a radiolucent area and radiopaque area. Let's see if we can take a look at the other adjacent periapical radiograph. Again, same feature is seen here, radial opacity and radiolucent component. Additionally, if you look at the incisors, I think I should have mentioned that on the previous radiograph, but you don't see any major sign of large restoration or dental caries, but rather just a lot of calculus deposits along the root surface. So let's go back to the other one more time. Again, there's some signs of attrition. However, no sign of caries. I know we're just missing the incisal edge here, but I don't see any major signs of caries once again, both at the occlusal level or the incisal level, as well as the proximal surfaces. Yes, we do have a little bit of overlap, but overall, no sign of caries, and patient is asymptomatic. Okay, so that's it. I just want you to see again how PCOD can appear slightly differently based on either panoramic versus periapical radiograph, and being able to detect these on panoramic radiograph would be a great skill to have. And let's see. Yeah, that's I think all I want to say for today's video. And just keep that in mind that these lesions starts out as a radiolucency, and we can call this that they're in a mixed stage, or mixed stage. And then as the lesion progresses, this will continue to become more radio-opaque. It could take years and years to do that, but just keep that in mind. Thank you for your attention, and if you like this video and learned something new, please hit the like button and please click to subscribe, as I'll continue to post 3 videos every week. Thanks again, and see you next time.